Starting from the second part of this lecture, we are starting from the testing of the eighth cranial nerve, that is the vestibulocochlear nerve. So we'll be testing the vestibular component separately and the cochlear component separately in this case. So the vestibular function, basically to check the vestibular function, will be testing the positional nystagmus. If you remember, you must have performed the test of for VVI, for vertebral artery insufficiency, that should be tested before any cervical manipulation and mobilization in that case if it is severe. So that was the very preliminary test to perform during testing of the during screening test before the performance of a cervical manipulation. So if you remember, in that position, patient is lying on the couch, and the patient head is extended off the couch in the first instance, and it is held in that position in neck extension for 30 seconds. And if there are no sign and symptoms, then the patient's head is rotated to one side, and it is again held for the 30 seconds. And meanwhile, the patient, you are instructed to look at the eyes of the patient, and if there is positional nystagmus, the patient's eyeball will show a to and fro movement. So this can be sideways, it can be up and down, and even sometimes it can be circular. So this was the method to check our positional nystagmus. And another factor, this can be included that in certain resources that include three steps. Like first is head extension, and like you will be holding the position for 30 seconds, and if the symptoms appear, you will stop the test right away, and then you will side flex the head along keeping in extension. You will side flex the head and wait for 30 seconds. If again symptoms appear, stop the test. If no symptoms appear, then add on the rotation, and then again wait for the 30 seconds. And if no symptoms are like apparent, and the patient is clear. And if symptoms appear, and that can be like dysarthria, that can be like nystagmus, then there can be the patient is a victim of positional nystagmus. So this is the way we can check the nystagmus, and we can check the vestibular part of vestibulocochlear nerve. So coming towards the cochlear part. So cochlear part is obviously, as you know, that here we have to check the hearing function. So we will test the auditory acuity, just like visual acuity, how clear your auditory function is. So the very preliminary test again, that can be performed is called whisper test or watch test. In whisper test or watch test, you will simply whisper in the patient's eye, and you will increase the distance from an increasing distance. Or you can take a watch, and you can like keep it near to one ear, and you will occlude the other ear meanwhile, and you will increase the distance and mark the point where the patient stops hearing the clicking sound of your watch, and you will check the and compare with the other side. On the other hand, you can check by rubbing your finger and thumb, and you will mark the point where the patient is unable to hear anymore, and then you will check on the other side. And once again, you will mark the point, and then you will compare both sides, that either the like distance is same on the both sides. So this is a test, but this is a very crude type of a test. This is not very refined test. So this true test is used to check the auditory acuity. So the other test used is called the Weber test. In that case, a tuning fork is used. Usually 572 hertz tuning fork is used, and the tuning fork, say this is a tuning fork, then this will be placed in the center of your forehead. And this is also called the test of lateralization. The patient has to report that either the patient can hear same on both sides or not. So the other situation can be the normal situation is that you can hear same on both sides. The vibrating tuning fork produce a sound. So normally, if the patient is able to hear same on both sides, then obviously the patient is normal. The abnormal finding is that obviously the patient is hearing loud in one side, and the other side is comparatively less loud. So now there can be two kinds of problem. Either there is a problem that In the ear where the patient is hearing loud, there can be conductive deafness in that ear where it seems louder. So what is the conductive deafness? Conductive deafness is like a problem or pathology in the conduction pathway anywhere from your external ear, from your eardrum to your middle ear till the middle ear. There can be a problem, then this is called a conductive deafness. Or on the other hand, the situation can be that the ear where the patient is not able to hear equally loud and it is hearing less sound, there it has sensory neural deafness, and neural deafness occurs in case where there is problem in the inner ear. So in conductive deafness, problem was in the conduction pathway from the outer and eardrum or anywhere in the middle ear. And in sensorineural deafness, there is a problem in the inner ear. So these are the two kinds of problem that can be identified through performing your vapor test. Another test is performed where we compare the air and bone conduction, and this is called the Rinne test. So in this test, the like if this is the tuning fork, then once the tuning fork is like held on your mastoid process, and the other hand, the twins are then kept closer 1 centimeter at a distance of 1 centimeter away from the ear. So the patient will tell you that which sound was loud when it was on the mastoid process or when it is near your external ear. So actually, the air conduction. This is the air conduction. This is when we are places on the mastoid. This was the bone conduction. Air conduction must be better than the bone conduction. So obviously, if it is not the case, then patient have some kind of problem, and we need to identify a further check is what is the what kind of problem that where is the conduction is problem. Air conduction should be better than the bone conduction. So this was the eighth nerve. Coming towards the ninth nerve, that is your glossopharyngeal nerve. Once again, both the sensory function should be tested, and also the other function should be tested. The sensory, the glossopharyngeal nerve is sensory to the posterior 1/3 of the tongue, and anterior 2/3 was supplied by facial nerve, and posterior 1/3 is supplied by glossopharyngeal. Obviously, the method of testing will be the same. We will take one saline solution and sugar solution and we'll apply it, but this time we'll apply on the posterior 1/3 of the tongue, and we'll see if the patient can correctly identify or not. The others, the sensory supply to the is to the pharynx, that can be checked through the gag reflex, and the another supply is to the middle ear, but that is usually not tested. So coming towards the gag reflex, here you usually press the tongue with the spatula, and you will touch the soft palate, very close to the vulva. You will touch this part of with a spatula, or sorry, you will touch this usually with a like stick with which will be on the approaching part. You will having a cotton on that, and so that you will touch this part, and as a reflex the patient will show contraction and elevation of this soft palate. So this is the gag reflex. So glass reflex, it has dual functions. Sensory is to this is ninth, and motor is 10th. So in this way, ninth and 10th both are checked through the gag reflex, and the ultimate result can be contraction elevation of the pharynx. On the other hand, you can simply ask the patient to say ah. In this ah, they will have to notice the movement of soft palate. Again, in saying ah, the patient can show movement of soft palate. Okay, coming towards the 10th now, vagus, only motor function is tested in that case, and simply the problems which can be here can be that can be paralysis of your larynx. In that case, you will see hoarseness of the sound, जैसे गला बैठा होता है, ऐसी आवाज आएगी. This is called dysphonia. So that is the test that this is not a test, obviously that is an observation that you can make that patient is having hoarseness of sight. Then obviously if there is paralysis of soft palate, once we have already checked the movement of the soft palate through gag reflex, then other we can see that paralysis of the soft palate will lead to the nasal quality of the noise. ऐसा लगेगा patient नाक में बोल रहा है, ठीक है. और उसके बाद another thing which can help you is to ask the patient to cough. The cough is also having a nasal quality, or the cough become bovine. Bovine means that भैंस जैसी आवाज जो होती है, ठीक है, मोरी बैठी हुई सी भैंस जैसी भारी आवाज पेशेंट की हो जाएगी. Coming towards the testing of the accessory nerves. Accessory nerves that you supply, as you know, it supplies trapezius and sternocleidomastoid. So to check the trapezius, you will resist the shoulder shrugging. And to test the sternocleidomastoid, you will resist the turning of the head. So you will resist the neck turning. So in this way, accessory nerve is test. So coming towards the last part of this, we are going to discuss the testing procedures for the hypoglossal. As you know that this is supply your tongue, so you will simply ask the patient to protrude the tongue out, and you will look at the shape of the tongue, its size. You will look for the wasting, and you will look for any flicker of movements if they are happening at that time in the tongue. So this is the way you will inspect your tongue. So if you, another very important finding is that you will see if the like tongue is protruded to one side, it is deviated to one side. This is an indication of unilateral hypoglossal nerve injury. You can see there are also some kind of wrinkles over there, and there is unilateral deviation. So this is an indication of unilateral hypoglossal nerve injury. The other thing you can be that you will ask the patient to like put the tongue along the cheek and will resist, and patient will resist this thing. You will resist this with your hands. The patient will be asked to like resist against your hand and put some force with the tongue. Okay, and this is a very interesting finding that there is a different picture in case of upper motor neuron lesion and in case of lower motor neuron lesion. If the damage is to the nerve itself, that is a lower motor neuron lesion, then the tongue will be curved on the same side and towards the damaged sides, to the ipsilateral side. And if the damage is to the pathway up where there is upper motor neuron lesion, then the tongue will curve away from the damaged side. That will be contralateral side will be affected. So it will damage away from the side of the damage, and there will be also no fasciculations or wasting, and speech difficulties will be more evident in that case if there is upper motor neuron lesions. So these were all the findings that you can find when we are like checking the cranial nerves, and it is very like preliminary, a very brief and very quick examination. If you will perform in a row, this can be performed within a couple of minutes. So you should be well aware of what are the normal and abnormal findings, and according to that you can refer to the patient to the possible physician if required, or if you can treat the patient yourself, then you can treat him more specifically. So that's all from this lecture. I hope you will find it